Hello, everyone. This is Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk, the place where emergency physicians, aka ER docs, come to talk about things that are important to us. Sometimes they're professional, sometimes they're personal, but they're always hopefully interesting and sometimes even informative. Today, I get to talk to my special guest that I have on periodically just for the fun of it, and she always educates me as well as pokes me in the eye, Jeannette Wolfe, and welcome to EP Talk, Jeannette.
So I just want to say special guest. That sounds like somebody your mom made you have on, or like somebody like you have. It's like your imaginary friend when you're in second grade. This is my special guest.
This is my special guest.
Mark, I'm so glad. I can't believe we haven't talked for like a year. We started, our last conversation was like right as the pandemic was just sort of rearing up. We had no idea what was ahead of us.
The 15 days to flatten the curve.
Oh my gosh. We were like naive babes in the woods. Who would have known?
Oh my gosh. You know, I'm in Annapolis, Maryland, and this is the home of the United States Naval Academy, and these poor suckers checked in here, and they came in June. Well, the plebe class of last year they came in June, and by the winter, you know, we had they locked them down, and that's called when you're restricted to the yard. The base, the Naval Academy, inside the fence, it's called getting fried.
Wow.
Okay, you get fried, and it's considered to be pretty severe punishment if you get fried for 2-3 weeks. The entire brigade of midshipmen, 4,000 of them, got fried for 6 months.
Oh.
They were not allowed off the yard for 6 months, and right now they're not allowed out of their rooms except for an hour or two per day to do PT, to run. And it is like a modern, I wouldn't say a medium security prison, to be perfectly honest.
Has it worked as far as decreasing the spread? I'm hoping the numbers were like almost zero.
They're college kids. Every time they let them out, they run out and they get a bunch of COVID and come back and they lock them up again. And nobody's gotten sick. They've gotten COVID, but nobody's gotten sick. Not that I'm aware of. I mean, it's kept them safe because every year, the midshipmen are pretty rambunctious group. They're skydiving and ice climbing and drunken driving and motorcycles and this, that, and the other. And it's really heartbreaking. We have 1 or 2 killed every year doing something. They haven't had anybody killed, but they hadn't had anybody out of the room yet either. I mean, they're all at each other's throats. I think they're all depressed as hell. And man.
Yeah, we were talking.
Give you an idea. Let me just say this, and I'll let you run with it. They told the midshipmen after they'd been locked down for the entire fall, they were getting ready for Thanksgiving, and then they said at the last minute they could not go home for Thanksgiving, and in 24 hours, every hotel room and every Airbnb in Annapolis was sold out to their parents coming to see them. Okay. And then 12 hours before Thanksgiving, they told him that the parents could not get on the yard to see their kids. They could literally see them through the fence.
Wow. How are their recruitment numbers for next year's class?
That's exactly rough. Right.
That's really rough.
I don't know.
So, our experience, we were talking a little bit before we got on the show, is my daughter's a sophomore at Clemson. Yeah. And she went through Sorority Rush Online, which
what is that?
I know. So, Mark, you might remember where I went to school. Did I ever mention where I went to school to you, Mark? For those of you who don't listen, it's a long-standing joke because I went to Notre Dame, and Mark is a enormous Navy fan, obviously. Yes, so every year
we beat Notre Dame after 30 years of dry season. We beat them in football. Yes. Navy beat Notre Dame.
That was a couple of years ago. That was a couple of years ago. Just saying.
A decade ago.
Well, just as a total aside, and then we'll hopefully talk a little medicine. Notre Dame and Navy have this long-standing tradition because during World War II, Notre Dame basically probably would have gone bankrupt had Navy not come in and sort of supported some of the infrastructure of the school with the ROTC. So forever, Notre Dame has an obligation to Navy because they essentially are fundamental for them staying open. So that's going to be a longstanding tradition that I don't anticipate going away.
Never. Navy Notre Dame, regardless of how powerful Notre Dame is with regard to Navy, it'll always be a big game. It's always sold out. They can't play it in either. They play it in South Bend, but when they come here, we play it at one of the professional stadiums.
Yeah.
And it's just a lot of fun. Anyway.
Well, going back to that story is that Notre Dame doesn't have any fraternity or sororities. So being a Notre Dame alumni, I was a little blown away by the whole Southern sorority thing. So it was an awakening for both my daughter and myself. Anyhow, talking about,
online,
well, you know,
but see, that's a tamed down version online, say.
Oh yeah. Well, and again, I just heard probably one of the first hazing deaths happened at VCU just 2 days ago. They found a male student the next morning dead. So
From drinking, yeah.
Yeah, so I think it's weird how like mass shootings have gone down through the pandemic. And, you know, we just talked about sororities and we talked about Navy. So later in this conversation, I can tell you one of the podcasters I had a chance to interview this year, and our subject was toxic masculinity, which is really a subject worth talking about as far as our response to this pandemic. But before we do that, why don't we talk about some of the sex and gender differences about COVID?
There we go.
Yeah, well, I think so. So there's just one take home. So I'm going to put on my sort of academic geeky hat. And my academic geeky hat would say the one thing I would really encourage your listeners to do is start looking at sex disaggregation of data analysis, which in English is, it's not just enough to say, in this study, we studied 1,000 people and 490 of them were males and 504 were females. You actually have to see how the outcome is sex disaggregated. And we still just have that fundamentally lacking in most medical research papers. And, you know, why the hell do we care about this? Isn't this just nitpicking some extreme feminist view?
Let me say it. It's because men and women are different.
Oh my God, Mark, after 20 years of beating you over the head, I think you're getting it. Wait, can you say that one more time? The bumper sticker's coming.
We're different.
Yeah, right. So
my wife has always said, with all of our differences, it's a wonder we can even communicate. And I kind of actually wonder if we communicate, but go ahead.
Yeah. So when we look at this past year, I think that the pandemic has kind of been a poster child as why the hell we should care about sex-based differences. Because, okay, I'm just going to give you some little quizzy questions, Mark. They're going to be really easy. I have great confidence.
These are fun. You always give me, and I always get them wrong. So go ahead, fire away.
So, you know, worldwide, who is more likely to die in this pandemic, males or females?
Oh, jeez. Females.
Mark, I'm going to ask you that question again. Worldwide, who is more likely to die in this pandemic, males or females?
Females. They're more likely to be diabetic, hypertensive, and obese.
So I'm so glad we're having this podcast, apparently. So worldwide, if we look at males are much more likely to die in this pandemic, depending on the overall numbers, like 1.7 times more likely. And in the United States, males are about an absolute 8% more likely to die. So,
really?
And that's probably rooted both in sex and gender. So just to go through some basic definitions, biological sex is usually binary. It's our sex hormones and our chromosomes that we're born with, whereas, you know, gender is much more on a spectrum and it's heavily based on our social cultural factors. And both of those can impact who gets sick. So I used to think we should be able to draw a nice.
Wait. You're telling me that if you're a biological male and you see yourself as a female, you're a little bit less likely to get sick because you see yourself as a female gender? Is that what you're saying?
Not quite, but I appreciate that you're trying to follow the conversation, Mark. So you get really big points for that. Let
Okay,
me,
okay,
so when I think about biological sex, what I'm saying is binary, like,
right.
for the most of us, we are
Real
either
sex,
male or
men
female.
and women.
And you're right. So you can be biological sex of birth male, and you can be identify your gender identity as a woman. So you would be a trans woman. But
You
depending
still got,
upon whether you've had uh, gender affirming surgery or gender affirming hormonal use, your biology may be
doesn't
more
change.
bent. So what we have found with COVID is that these rooted biological sex-based differences are actually pretty important. And they're probably rooted in two huge differences. The first one being differences in the immune response, and the second one being differences in the RAS response. And for those of us who don't remember what the RAS system is, it's their renin-angiotensin system, which gets really boring really quickly. So what I want readers and listeners to think about is imagine that you're the system that controls your blood pressure, your water
In your lungs,
reabsorption, and your
and
sodium.
kidneys.
Yeah, exactly. The fulcrum of that system, if it's a teeter-totter, the fulcrum of that system is this ACE2 receptor.
Right.
So if you go too far to the front part of the system, you get hypertension and you get increased inflammation. If you go too far on the other side, you get vasodilatation and anti-inflammatory processes. So they think just in general, this teeter-totter in males, especially middle-aged males, is much more sort of uh, swayed towards the hypertensive and pro-inflammatory stages. Whereas for females, because estrogen tips it the other way, they have more natural vasodilatory and anti-inflammatory processes. So when we look at patients who are getting sick with COVID, that whole RAS system is getting really screwed up. And in general, everybody who gets severely sick with COVID gets tipped more towards that hypertensive pro-inflammatory state. So that's that's the big sort of thinking difference as to this whole ACE2 receptor, which gets super complicated very quickly. And then the second thing is just how males and females different in their immune response. So if you get an infection, Mark, for you to get better, you have to have this innate response, which is your body recognizing that it's been invaded by a virus. Then you have to have an adaptive response, which is your antibodies and your T cells and your memory cells. And then you have to repair all those tissues. Every single one of those steps has a biological sex difference. So in general, females are much more likely to have a strong innate immune response. In general, females are much more likely to have a much more robust antibody response after vaccines. And in general, females tend to do a little bit better in tissue repair. So these
I thought you said that
differences,
the males had a higher inflammatory response.
they, so it's really interesting. So you nailed the conundrum of SARS-CoV-2, because when we think of people getting super, super sick, we think of people having this super high inflammatory response.
Right.
So these
Phase
two
two,
systems,
yeah, infection, inflammation.
exactly. So these systems are in balance. So if your RAS system isn't totally balanced on that fulcrum or bent toward the anti-inflammatory, and then you have this different immune response. So what they are thinking is that males are more at risk for a maladaptive immune response because it's all this fine adjusted system. If you don't turn on and off the switches at exactly the right time, you turn it on too late, you turn it off too early, then the system doesn't work right. So what they think happens is males are late to the game in their initial innate response to SARS-CoV-2 infections, males at least who get severely sick, and then they don't turn off their they don't turn off their pro-inflammatory response the way they should. So testosterone is really interesting in that.
Wait. Okay. Let me stop here. So what you're actually saying is they don't respond, so they have a tendency to get more of a viral load. They don't respond quickly enough, and they get more of a viral load. And then because they got a more of a viral load, and because they start an inflammatory response and they don't shut it off, you get this hyperimmune, or more likely to get a hyperimmune inflammatory second phase. That
So we're
sucks.
still learning all the details about this, but there has been some early studies that suggest that males, when they get infected, tend to have slightly higher viral loads. And when they should turn things off, and some scientists think that this is sort of an over exaggerated response because they didn't do their innate response quite the way they should. So they said, uh-oh, we're way behind and we're going to start getting our cytokines turned up. And the bad cytokine that's in the news a lot is IL-6. But
Right.
here's something I've also really learned about the last year. Like, immunology is super complicated. It's not something you can pick up by 3 hours of reading. There's
Yep.
like more than 20 different types of cytokines, and your head can explode when you read it. And if you block IL-6, guess what? There's all these backdoor mechanisms that allow you to start an inflammatory response by a different pathway. So it's not super simple. But what the bottom line is, as I see it, is if you don't have these incredibly well-timed, like I said, turning off and turning on of different parts of your immune system, then you're more prone to get sick. We also know that these are totally influenced by the aging process. So as people age, there's new data saying that, especially males, their T cell response isn't quite what it should be. But there's all these paradigms with SARS because, like I said, you would think that in general, because women are more likely to have a more robust immune response, that they would be the ones that would have this hyperinflammatory response. But
Yeah, I was just
that
going to say,
doesn't
aren't they?
seem like that's the way it is with this disease. So
Yeah, don't they have a tendency to have more of the, say, I wouldn't say mixed connective tissue diseases, but like
inflammatory diseases, yeah,
inflammatory disease.
autoimmune, exactly.
Autoimmune. Yeah, thank
You're
you.
exactly right.
Autoimmune, they're more likely to have autoimmune diseases than men.
Yeah, you're exactly right, because this turning on your immune system and revving it up, it generally protects females from getting a lot of infectious diseases that they have less likelihood to get super sick from than males do, but it also sets them up for this autoimmune response. And some of that has to do, getting into the nitty gritties, and we can sort of talk in general on some other subjects because I can get dry pretty quickly, but I think it's really important, is this the X chromosome. So we know that like ACE2 inhibitors live on the X chromosome. We know that this receptor called toll-like receptor 7, which is really important to saying, hey guys, your body's been invaded by this virus, do something. That is also located on the X chromosome. And what we know, males have one X chromosome, females have two. And in general, one of those X chromosomes is turned off in most people's cells. But we know that in some of these inflammatory markers, like the toll-like receptor 7, and maybe with ACE2 receptors, that second X chromosome is not totally becoming inactivated, so that females might have an overexpression of that gene. So this toll-like receptor 7 that says, hey, your body's been invaded, one of the things it does is it triggers an interferon response, and females seem to have, in general, a more robust initial interferon response, which might be another way that, in general, females might be slightly more protected from this. So it's
females
not just
better. Oh, let's just face it, females are just better.
As I actually want to change people's views as to why this stuff is important, I'm just going to stay way far away from that, at least until we stop recording. But I think this stuff's super important. So like, it's not just, sure. And then all of these immune cells, or at least a huge portion of them, have sex receptors for hormones on them. So they have receptors for testosterone and for estrogen. But just to show you how screwy this little virus is, because some people think the reason why this virus is so good at making us sick is it sort of stuns that initial innate response, saying that in most cases you get this immediate recognition that your body's been invaded by this virus, and then you get this huge interferon surge. Well, it seems to do something to say, hey, we're going to trick the body to not let it know it's infected. And that's one of the reasons why this is so contagious, because the viral loads are the highest the day before people become symptomatic. So your body hasn't even really adequately recognized that it's been invaded yet, when we're the most infectious to other people. So I think that some of the reasons why this is important, if the stuff for me, as somebody who's looked at this material deeply for 10 years, but has never looked at immunology before, at least to this step. Like if you told me I was going to be reading about ACE receptors and toll-like receptors a year ago, I would have said, Mark, you're smoking something. That's not going to be, I'd rather work at a low back care clinic for follow-up patients. Like, I'm not going to do that. But you start reading this stuff, and you immediately realize that the fundamental science of this area has not been looked at by sex disaggregation. So we're just learning about how males and females have hugely different immune response. Like we know some stuff, but there's so much more we should know. And to give you an example as to why this is relevant, testosterone. So let's just talk about testosterone for a second. There are studies out there that say patients who have prostate cancer, who have blocking of their testosterone receptors, are maybe less likely to get SARS-CoV-2 because they don't have this TMPRSS2 protein that sort of lyses things to let the cell get invaded by the virus. That's like one theory. There's also other theories out there and data that says if you're going into the ICU with SARS-CoV-2, you are much more likely to be hypogonad, and that half the people getting admitted to ICUs with COVID have low testosterone levels. So consequently, there are studies right now.
The testosterone, if you're have low testosterone, you're more likely to do poorly. That would be more like a woman, more female.
Well, but you're not having the estrogen though. So it's all, we all have progesterone, estrogen, and testosterone. So it's this cocktail. So you get rid of one. Estrogen. So it's not. So right now though, Mark, there are studies that are going on that block testosterone, and there's studies that are going on that give testosterone. So you're like, really, we can't even figure out if this is going to help or not. So I think it's fundamentally interesting. And going back to testosterone, you know what testosterone also does, which is associated with clinically important outcomes in COVID? Like, what do patients get when they're admitted up into the ICU with COVID? What other big complications do they get? Swollen legs.
Coagulopathy. Yeah.
So do you think people on testosterone have lower or higher coagulopathy risk than people who are not on it?
Lower.
Much higher. Like I had no idea about that. So if you're on testosterone supplements, which let's be honest, Mark, of all the males over 50 who are on testosterone supplements, how many actually really need to be on it? Do you have any idea? Because I know that answer.
I don't know. I've never thought about it.
The vast majority do not. Probably like 1/3 have a medical reason to be on it. Others are on supplementations because of why guys are on testosterone supplementations.
Yeah, they're on other things as well.
Well, so that increases your risk of blood clotting. And if you look in general, forget the testosterone supplementations, there's been some meta-analysis that say who clots with COVID? You are about 1.5 times more likely to clot with COVID if you're an older male than if you're a female.
Oh.
Which is like against, again, everything we would have ever thought. Because when we look at PERC, we're thinking about women on estrogen, right? That's
right.
So I think that all this stuff we just haven't really thought about to a degree before. So let's say, so the idea with testosterone, why it might be theoretically helpful for patients who have SARS-CoV-2 serious infections. One, this whole going back to the immune system and this IL-6, when your testosterone levels go low, you're much more likely to have increased inflammation. So as men age and their testosterones fall, they're much more likely to have a little bit more of a pro-inflammatory response when they get sick. So the feeling is that testosterone might actually block IL-6, which is one of these cytokines that gets people sick. So say, okay, we're going to give these people going to the ICU testosterone. Well, that might really change their blood clotting profiles. So maybe they might need more than regular anticoagulation, or maybe they all need anticoagulation. So I think these questions, again, are things that we haven't really thought of much before, but when you start thinking about it, probably has clinically important relevance for our patients. So that's what I've been doing the last year.
So maybe okay, my gosh, I thought I had this thing sort of sorted out, but now you're telling me that if they're hypogonadal, they're more likely to have higher inflammation, but if they're hypertestosterone, they're more likely to have coagulopathies. So you're screwed one way or the other, you know? So which would you rather do? Die of inflammation or die of coagulopathy? I think I'll take the coagulopathy.
Yeah. Well, I think it's just, again, sort of things we've just not thought of before. So
Yeah. It's a
it's interesting.
complicated disease. My
Well,
gosh.
the other thing is, so, we talked about that women in general have higher antibody responses. Well, who has the best antibodies after they have had SARS-CoV-2? So if we believe that there is still a role for convalescent serum, which is controversial, but let's say we believe there's a role for people who aren't sick, who are in the outpatient world, who might benefit from convalescent serum because they have multiple comorbidities. By the way, one of the obesity decreases your testosterone level,
Right.
and obese men, they actually make a lot of estradiol in their fat tissue. So they kind of get a double whammy. So estrogen's a princess. At low levels, estrogen does a totally different thing than at high levels. So your response to estrogen depends upon the concentration, the type of receptor that it binds to, because there's two different types of estrogen receptors, and where in the body it's binding to. So low levels of estrogen can be slightly pro-inflammatory. Higher levels are more associated with anti-inflammatory and B cell production. So if you imagine you're an obese guy, you have hypertension, you have cardiac disease,
And don't
you've got
start
the
talking about
perfect
fat
storm.
guys, okay?
I'm going to be politically correct again because I'm trying to encourage people to think about this stuff and not get pissed off at me.
Okay. Nobody's going to be pissed off. They're going to be confused, but they're not going to be pissed off at you. Okay.
Well,
But
so
so far you've got my head spinning. I don't know whether I should have small gonads or big gonads, or whether I should be fat, or whether I should be oh geez.
well,
What the
let's
heck?
put it all together. Let's just use the idea of a morbidly obese guy,
Okay.
biological sex male,
I'm morbid.
who has hypertension and cardiac disease. Let's look at the double whammy a SARS-CoV-2 infection could get them. So what's
Yeah.
happening to their RAS system? Because they have hypertension and cardiovascular disease, it's
Right.
already tipped towards that hypertensive, vasoconstrictive,
Right.
pro-inflammatory stage.
Yep.
Then on top of that, you've got lower levels of testosterone because they're older. And when you're obese, you also lower your testosterone levels, I believe. And you have increased levels of estradiol because in your fat cells, you can make estrogen. So low levels of estrogen are pro-inflammatory. So these guys get screwed because their RAS system is totally dysregulated. They get screwed again because they're obese. And then they get screwed again because their testosterone and hormone levels are all over the place. So I think
Wow.
it makes you have a better appreciation as to why some of these folks are so sick.
You know, one of the docs who was talking about preventing COVID. It was a family doctor. He got a lot of press early on, and he was just talking about how difficult it was to sort this whole thing out. And he said, my patients don't get COVID, and he was being kind of um, hyperbolic about it, but my patients don't get COVID because I control their hypertension and I control their obesity. And he was just looking at all these risk factors like you're talking about and saying, why wait till they get COVID? Why aren't we aggressively going after all these situations that create such a high risk for them? I think he had
So
a
his
point.
patients are probably well-educated white people who actually follow their doctor's advice. I'd like to see the social
That's not bringing
economic class
research
of
to it,
backup.
but yeah, I think that he's aggressive. He's aggressive with his patients. Yeah, and now you bring up race disparities, and everybody always tries to say it's because they don't have access to care, but is that the case? Is it because of lack of access to care?
It, yes. So I want to finish this
Okay,
comment, and then I want to go back to that convalescent serum one in case anybody was like
okay,
listening, going like, "Hey, we never finished that."
okay.
So one of the huge awakenings, and I'll share this to you just on a personal level. Mark, what do I study? I study sex and gender. Like that's my
Mhm.
passion. That's what I've delved up
Right.
deeply into in the last 10 years. When
Hmm.
I read sex and gender articles on any sort of outcome, whether it's who gets paid more, whether it's who is more likely to become a professor, whether it's who
Yeah.
is more likely to get a cardiac cath, whether all of that stuff. In general, there's always an asterisk in that whatever you're finding that difference between males and females, it is much worse if race is involved. So the intersectionality of sex, gender, and race is huge. And honestly, until the events of this past year, I was like, that's somebody else's lane. I do sex and gender. I don't really do race. But the truth of the matter is, we all do race. If you're a doctor, you do race. And in the last year, we have had to understand that things that, again, maybe we've never thought about in a deep level, incredibly impact the health of our patients. So race impacts the health of our patients because many patients have had, simply due to their race, not due to their baseline genetics, a difference in from day one, where they live, what schools they go to, what nutrition they get, whether they live in a place where they have a grocery store
fast food versus healthy diet. Sure.
And then the other big thing, and I had the fortune, I had the chance to have Lauren Parker on my podcast. I think it was the last one I posted. And Lauren Parker is a researcher at Johns Hopkins, and she looks at health disparities. And she's published a couple of papers of how do we reach men, specifically men of color, to engage more in their health. And let's be honest. If you're a female, chances you have ovaries, chances are there's a good chance you might want to have a baby somewhere between 20 and 40. That's your access to healthcare. You're going into healthcare for gynecological health. So most females have a natural entrance to the healthcare system from their well check to their obvious something's really wrong. I'm getting chest pain, and now I walk into a doctor's office at 39 and man, I have hypertension and high cholesterol. How long have I had this? But there's no natural entrance point for males in our healthcare system during that entire period of time. Right. So her whole talk is how do we engage people in health, and particularly how do we engage people of color in health? And it was really interesting because we have to change the entire model of healthcare on its head. We can't wait for them to come to us. Like you can have diversity and inclusivity posters all over the place in your clinics, but if they don't walk into your clinics, they're never going to see it. So how do we bring medicine to where it's needed the most? And quite frankly, we have a long way to go in making medicine trustworthy in some of those communities, just due to the very long history of disparity care.
I mean, the vaccination isn't running into that right now, and that is all the various, in my community, I'll hear people joke about it. Have you been injected with the microchips yet? And everybody knows it's kind of a joke, but in some communities, some of the concerns about what exactly is there. I had a patient tell me the other day that there was antifreeze. There was antifreeze in it was in the vaccination solution to keep it from freezing.
Well, I think you go immediately there. Where do people get their information?
Right.
And we are not effectively sending accurate health messages to huge pockets of our community. And this isn't the first time that there's been racial differences in vaccinations. I was reading an article a few days ago, and I think it was the measles vaccination when it first came out in the 70s and 80s, where they were directed away from private clinics away from public clinics into private doctors' offices. So where they were seeing these outbreaks were not in kids who had access to good regular doctors. They were seeing it with kids from poor zip codes. And interesting enough, there is a group of people who are trying to really engage social media like Facebook. Facebook will say, like, we don't have racial information on people, but what they do have is zip codes. And we know that for many areas of our country, your zip code is pretty heavily related to your race. So there's people that are saying, look, Facebook has this information already to target advertising to this particular geographic area. Why can't they effectively do some public service and target accurate health information to people who need it most? Because let's be really honest, who is dying? It's just not overweight heavy males, it's overweight heavy Black males.
Yeah, yeah. And to say that they don't have that information is disingenuous because they have it through a variety of other, zip codes is just one of 1,000 different touch points that would identify, your race, by what you buy, by what, there's all a gazillion things, artificial intelligence can tell a lot about you and not just one factor of where you live. If
Oh,
Facebook says you can't
is
they'll
that why
tell
my
you.
pregnant au pair who went back to Canada, who was not pregnant when she was my au pair, but she went to Canada, like she was my au pair, went to Canada, got married, had several kids, and we got diapers delivered to our house. So somebody had her demographics in a database to send us diapers to her
Connected to
at our
your
house
house.
from 4 years later. So I
Yeah.
think you're right, that data is out there. Just to loop back to convalescent serum, because I think it's
Yeah.
important. When we look at antibodies, who seems to have the highest antibodies, again, we would anticipate from other studies that females should, but the best antibodies for convalescent serum seem to actually become from males who almost die. And in some ways, that kind of makes sense. Like if you didn't get killed by this and you were on the verge of it, your
That's right.
body revs
What
stuff
doesn't
up.
kill me makes me better.
Yeah, it came in the bottom of the ninth with 2 strikes out and the intubated ventilator almost getting ready to do last rites. And all of a sudden, your
He
IgG
walks
and
away.
IgM said, come on,
I,
Mark, we can do it.
I want some of that stuff.
So, in the NHS system in the UK, they have preferentially gone after male convalescent serum because of that, because they have higher levels of antibodies. So that's a biological sex difference. The gender difference, who donates their antibodies in the UK? Do males or females, men or women?
Men. No.
No. So even though again, who would have thought that women were
Yeah.
far more
Yeah.
likely to donate convalescent serum? Like who would even think of that being relevant? But
Yeah.
again, if you start looking for this stuff, you find it in nooks and crannies you never anticipated, and sometimes it's really clinically important. And
Yeah.
the other thing I will say about convalescent serum is there's probably about 15% of people who have super sick disease with COVID who have antibodies against interferon. So they don't know if they create it because of this virus or whether they're born with it.
Interesting.
So the problem with that, or they don't have a gene that makes it, you probably don't want those folks convalescent serum, right?
Right.
So I'm always sort of curious in these convalescent serum studies versus the monoclonal antibody studies. What are you actually getting? Like if I get your serum, Mark, what am I getting antibodies to? Am I just getting it to SARS or am I getting it to everything else? And I think that kind of matters too. So who's getting the serum and who it's donated from, or who's getting the convalescent serum and who's donated from is again a consideration that we haven't thought about.
Amazing. Absolutely amazing. Every single time that you come on with me, I learn so much, and I'm always about 180 degrees away from the right answer. So that's fun when you question me. So Jeanette, it's always great, absolutely great. And so if I were to sum up, I would say that men are more likely to die because they're late to the game and then they hyper react, which my wife would probably tell you that's probably true and other things as well.
And that's
and then there's both you can be hypogonadal and lack inflammatory response, or hypergonadal and be hypercoagulable. So it just you're screwed being a guy.
well, and that's just talking about the biological sex. We haven't even talked about gender differences as far as exposure and all those
Yeah.
things. We can
Oh
maybe
my
talk about
gosh.
that
Oh
in
my
a
gosh.
different idea.
We'll do that again at another time.
Oh, you want to talk about toxic masculinity for 45 minutes? I
No,
thought we
no,
could do that
no.
at
I don't want
another time because I bet we have an N of one that I'm interviewing that could give plenty of examples.
to. Okay. Well, it's absolutely a pleasure to always talk to you. You have one more thing.
So
One
I
last.
just want to say that my big take home point over and over again is just for readers to look at studies when they come out to see if they did sex disaggregation of the results.
Yeah.
Because you don't
They don't.
know what
They
you
don't.
don't study, and you can't fix a problem if you don't realize it's there. So paying attention to outcomes by sex is important. Sometimes it's not relevant at all, but sometimes we find these things like these huge differences in clotting that are really important that we would never notice if we don't look for them.
Yeah. 'Tis true. 'Tis true. Jeanette, it's always great. It's always great. And for our listeners who have joined us for EP Talk, as usual, you've got an earful from a very, very smart gal. So I appreciate you coming on, and we'll have to do it again very soon. And this time next time we'll talk about gender.
As always, Mark, it's always so great to connect with you. For people who don't know, Mark was super influential in my own career because he gave me a chance to write and have a bigger voice for issues that are important to me, and I hope are important to many other people in emergency medicine too. So stay safe. I always enjoy talking to you. Thank you, Mark.
Okay, guys. See you next time. Thanks for joining EP Talk. Bye now.